Ladies and gentlemen, dear colleagues, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to welcome you here in this scientific event, which was a continuous series of the vaccine talk that we had it a couple of months ago. So in continuations, to reinforce our competencies towards the vaccinations with a special focus on herpes zoster vaccine. So I would like to thank you for your attendance, and I would like to thank our eminent, prominent speakers who have been, we have been privileged to have today. We have Professor Mustafa Shemeri, consultant cardiology, internal medicine, chairman of the Cardiac Science Department, College of Medicine, King Saud University in Riyadh. And we have also Dr. Muhammad Al-Lumi. He's a consultant nephrology, transplant kidney, King Salman Center for Kidney Disease in Riyadh, director of King Salman Center for Kidney Disease and Nephrology Service Line Lead at Riyadh Second Healthcare Cluster. Also, we have been privileged to have Dr. Ali Saeed with us. He's a director of Medical Services, the MAM Medical Complex, and consultant infectious disease. In fact, we were supposed to have Dr. Saad Zahrani, but for certain circumstances, he apologized. So we will continue our scientific sessions as we go. So, ladies and gentlemen, you know that we have started this campaign, which has two main domains. One is towards the public to elevate the awareness of the public towards the vaccinations with herpes zoster. And in the past 2 years, alhamdulillah, we have secured a tremendous success in having this kind of mindset of our population to attend the clinics and to receive the first and the second dose of herpes zoster vaccine. Not only this, but also we went to the other domain to improve our healthcare provider perceptions and their commitment towards recommendation of vaccine and to hold themselves responsible and accountable to secure the best interests of our community and the best interest of our patients with a special focus on special populations. And this is exactly what we are going to have today. Our session today is going to focus on special population at risk, those people those patients with cardiovascular disease, kidney disease, and even diabetes. So with this, we have been privileged to have these different specialties around the table today to have a discussion. And through the discussions, we are going to highlight the whole spectrum of the topic that will be related to these different disease entities. And with this comprehensive talk, hopefully, inshallah, you will carry a wealth of information that will help you and to give you the full confidence to recommend the vaccine and to go ahead with our responsibility. So, ladies and gentlemen, I would like to mention that our faculty here today, Dr. Saad Zahrani, Professor Mustafa Shemeri, Dr. Muhammad Al-Lumi, and Dr. Ali Saeed. I'm Dr. Ashraf Amir. I'm a consultant in family medicine. I'm the Vice President of Saudi Society for Family and Community Medicine. I'm privileged here today to be the moderator for this wonderful session. So on your behalf, I would like to thank all the guest speakers for accepting the invitation and to be part of this wonderful gathering today. I would like to disclose, this is the disclosure, all the speakers and moderator are not GSK employees, and all the speaker and moderators are receiving an honoraria for this presentation, and these slides have been developed by GSK. So the topics that we are going to highlight today, it's a different domain, herpes zoster disease and the impact of the underlying conditions in cardiovascular diabetes and kidney disease, the design of the different trials and efficacy and safety data in comorbidities, and the current herpes zoster prevention guidelines in comorbid challenges, and then we'll open the floor for any questions will be delivered to the experts. And then hopefully, inshallah, at 4:30, we'll be able to wrap up this session. Before we start, I would like just to scan this QR. So this is a pre-test before the event. So this will let you know how you can go through the different 7 questions, and then we'll be having another post-test after the event, so you can judge your capacity to build up your information and data as we go through the presentation. So without any further ado, we would like to start by our session. And the first questions will be directed to Dr. Ali. Can you give us a refresher on the pathology of herpes zoster infection?
Thank you, Dr. Ashraf. Thank you for Saudi Society of Family Medicine and GSK for invitation. I'm happy to be among colleagues and friends and for this educational pattern. Uh, so just to start, varicella zoster virus is one of the alpha viridae family of herpes virus that happen in two forms. The first form will be chickenpox, and the other form will be the shingles, which is the herpes zoster. So usually we have the chickenpox while we are in children, in child age. And once we have that disease, it will be dormant in the ganglion, in the dorsal ganglion in the body. And with time, the age will decline the immune system, and it will have at that time moment of possible reactivation, which will happen as a herpes zoster. So herpes zoster is reactivation of the varicella. It can happen in different forms. It usually presented as a skin lesion. It affects the neurodermatology system of the body. It can appear as a painful pruritus region, and it can affect various sites of the body. Because of its cause, it will not cause a lot of more mortality, but it causes a lot of morbidity. This is globally, and this morbidity affects the human function. And that's why it's very important to have a prevention strategy for herpes zoster. So as you can see in the slide, herpes zoster can appear as a skin rash, a painful skin rash, can appear in multiple parts of the body, can even affect the ophthalmology system of the body, and it can cause risk in terms of decline of the body function for the patient. I'm not sure why the site is not here, is not activated, but usually the risk factor for having herpes zoster is aging. So with age, our immune system will decline. And with declining of the immune system, you will have high chance to reactivate the herpes zoster. Another chance is once the patient has immune compromised status, whether that's acquired or intended by having, a condition like cancer, HIV, or chemotherapy, or having biological agent, or having a decline in immunological system in terms of that. So just to summarize, this is the primary infection, which will be the chickenpox, as you can see in your left side. And once that chickenpox disappear, it will be in the dormant agent in the ganglion, and it will be reactivated in the future, and the risk factor will be the aging. And this is the site where the chickenpox or the herpes will be hidden in our nerve system. This is just to show you how is the grade of having herpes zoster. So usually it started with vesicular lesion. It formed to be pustule, then it will be crusted, and then it will be scarred, and sometimes it can be persisted for a while. It is very important to know the stages because of infectivity. So usually whenever the vesicle and pustule lesion, this is mean high infectivity for the patient to spread the disease. As we know, the spread of the disease or having herpes zoster, it can be through two main pathways. Direct contact with a skin lesion, vesicular in particular, or through airborne or droplet inhalation from patient who has infected vesicle. So those rash can happen in any part of the body, but mainly they are coming in the thoracic part. It can be happen in the cervical, lumbar, cranial, and particularly any part of the body. It is very important to know where is the dermatome, because the dermatomal affected, it will mean the severity of the case. So usually whenever you have multiple dermatomal, or if you have insensitive area, especially the eye, that means this patient is at high risk of having more complication. And sometimes it need to be hospitalized and given IV therapy for that. So again, the risk factor or the main risk factor is aging. We know that aging decline the immunity. Whenever we are growing up, our immune system will decrease. Plus, there is a lot of risk factor having comorbidity, infection, diabetes, another co-infection that can happen and reactivate the herpes zoster. The slide, as you can see, the beginning, usually we will have the chickenpox, and with time, it will be hidden in our nerve system. So with time, whenever we have condition that cause our immune system to drop, like immune compromised status, or we have aging, we will start to have the risk factor of having herpes zoster, as you can see in the slide. And the black dot, it reflects if you have immune compromised status. So usually if you have immune compromised status, you will have at that condition, or you will be at risk of having that condition as early as possible.
Dr. Ali, there is a question. Do we have to have the skin lesions to diagnose herpes zoster, or there are certain cases where we miss this kind of skin lesions?
Excellent question. Actually, the majority of cases will be presented with skin lesion, but sometimes it will be atypical skin lesion, or it will go to an experienced physician, or it will be hidden by the patient. He will think this is allergies secondary to some clause or something. But there are some cases will present it without skin lesion, or the skin lesion will be very delayed, especially if it is in sensitive area, or in population where that area will not be able to be examined by physician sometimes.
From your own clinical expertise, what is the most prevalent dermatome that we encounter in our society?
Usually thoracic or lumbar. Yeah.
Could be more than two dermatome happens at the same
Actually,
time?
it happens sometimes, yeah. Especially if those patient has multiple comorbidity like diabetes or prolonged condition, they will present sometimes with a severe or multiple dermatome.
Okay, thank you.
So this graph, as you can see, this is just show you the incidence depending on age. So whenever we start across age of 50, you will have a slope incidence of increasing the incidence of having herpes zoster infection. And this is just some data from multiple countries. As you can see, it's almost the same. It's sharing that with age, you will be at risk of having herpes zoster. So again, the other risk factor would be comorbidity. So we spoke about aging. Aging will be decreasing the immunity, but we have also another co-infection or comorbidity, diabetes, cardiac issue, renal issue, COPD, lung cancer, immune compromised status. Those conditions will increase the threshold of having herpes zoster in those conditions. It is worth to mention that if you have, or the patient has, more than one comorbidity, he will be at higher risk of having herpes zoster. So if a patient has diabetes and renal failure, or CKD, those patients will be at higher risk to develop herpes zoster. And this is applicable for all the co-infection or comorbidity, sorry for that.
And this is actually the profile of patients that we can encounter.
Exactly.
Multiple comorbidities. It's not only diabetes, it's a metabolic syndrome with the complication of the chronic disease, subject our patient to be at high risk, as you said.
Exactly. Majority of the patient will be 50 plus. So probably they will have type 2 diabetes undiscovered, for example. They will have mild injury in their kidney. I mean, sometimes they are smoker, but they are not diagnosed with COPD. So we are seeing those category of patients who have multiple, especially in those patients who are admitted in the hospital, not seeking the attention in the clinic.
Absolutely.
So this is just to conclude or to show the risk factor of having comorbidity of developing herpes zoster recurrence or infection in terms of that. So if you ask me about, the question is very clear. What's the gap in managing those? So as mentioned by Dr. Ashraf, sometimes it's misdiagnosis. This is, I think, the major gap. Although now, with transformation, we have a lot of family physicians across the kingdom, but sometimes the gap will be from the patient. The patient will present it very late, or he will present it for the wrong specialty. Some of them will go for urology, for example, not for dermatology, not for the family medicine. So the first gap, I would say it is from diagnosis. The second gap will be from education. What's the risk factor of having this? Am I at risk of that or not? I think also another gap will be vaccination. So not all of our population are educated to have Shingrix vaccine or herpes zoster vaccine. For many decades, we are educated about influenza, maybe meningococcal because we have a Hajj season.
Yeah.
But for herpes zoster per se, there is not, a mass education for the community. And I think this is the major gap in terms of the health system. Early diagnosis, maybe early referring, and prevention for those conditions.
Absolutely. I truly second what you said, but looking into the real problem, we we can categorize into three different domains. One is the patient and community factors. So our patients and the community, they're not really aware of the disease and how it's progressing and what is the complication of post-herpetic neuralgia, which is a devastating disease that impairs the quality of life. And the vaccine hesitancy that is related to the patient and the community. When we go to the second domain is the physician, the clinical inertia. We are not in a position to diagnose those clinical entities in early stage, and we relate just only to the infectious disease or to the dermatology rather than all the specialty that share this kind of responsibility. The third domain is the healthcare system, the availability of the vaccine and
Prevention strategy.
the prevention
Yes.
strategy
Yes.
and so forth, and elevating this kind of the vaccine fatigues that we
Course,
had it
of
after
course.
the
And
corona.
anti-vaccine.
And
We have a lot of
anti-vaccine.
anti-vaccine.
Absolutely.
Yes. This is, I mean, a huge gapping, and this is not concluding only in Western country. We are seeing it in our countries.
Absolutely.
I mean, those patients who believe of that vaccine will harm them at least.
Yeah.
It should be educated for those category of
Absolutely.
patient. Regarding the second point of healthcare system, as you know, our health system is transforming from purely government to hybrid, I would say. So prevention was, I will not say was absolute not available, but I will say it was not priority maybe for decision maker at that
Yes.
time, because we will build more hospital, we will build more family physician, we will build more primary health care. But nowadays we are thinking about prevention those conditions.
Absolutely.
Because imagine that patient, as you mentioned, has post-herpetic neuralgia. I'll give you an example. Imagine you order food through application and there's no driver because he has sick leave at that time.
Yes.
It will affect life. So those condition or side effect of herpes zoster will cause morbidity for community.
Absolutely.
So again, this is just to summarize, I mean, to conclude again, that the patient who are at high risk of having herpes zoster will be the patient above age of 50. It's considered to be the start of dropping or declining or dysfunctioning of the immune system gradually until it reach that point where reactivation will be at high risk. The other category will be the immune compromised status. The immune compromise, again, it can be some genetic disorder, which will be seen maybe by our colleague, the pediatrician. And with effective and medicine, now some of those categories are reaching the adulthood. And the other category will be HIV, transplant. I mean, patient who receive chemotherapy, biological agent, those conditions are considered to be immune compromised status, and those are at high risk of having that condition. So again, I mean, we have a lot of strategy to do that or to do treatment. And the strategy, it depends actually of early diagnosis. So if you pass the 72 hours, which is 3 days of early diagnosis, the antiviral agent will be at minimal effect for those category. So again, this is one of the gap or of the gapping in the map or gapping of the strategy of having easy access to diagnosis or easy access to treatment. Those patients will have, of course, neurodermatological pain, and they will require strong analgesia sometimes. They will need, I mean, hydration because of those medication. And as a prevention strategy, we will need the vaccine. So the vaccine was available since 2006 as a Zoster vaccine live. Currently, it's on hold, but we have the recombinant, which is active since 2017. I mean, the live vaccine will be obviously contraindicated in patient on center category level, like a pregnant patient or patient on infection or immune compromised status. You cannot give live vaccine. However, the recombinant vaccine, you can give majority of those conditions. So I'll take this question regarding diabetes. So again, diabetes, if you ask me about the main comorbidity regarding those patients present with herpes zoster, I will say it's diabetes. Diabetes is well known to dysfunction the immune system. And diabetes, it's not only dysfunction the immune system, it's even will make the healing process very prolonged. And those patients will have, more side effect or more categorized. So this is a complex slide that's showing you that diabetes will affect our immune system. that it will affect eventually the polymorphic neutrophil, the lymphocytic neutrophil. That will also affect the innate immune system, and that will have increased the chance of having herpes zoster infection in those category of patient. This is, I mean, multiple studies done in multiple ethnicity and countries regarding diabetes relation and herpes zoster, and they all conclude that diabetes is a major risk factor of having herpes zoster infection. Again, diabetes increase the chance of having post-herpetic neuralgia, which is a major side effect on comorbidity happen in those patients who have the herpes zoster virus. And that condition is actually affecting the patient life because the pain will struggle for sometimes many weeks and many months until it starts to recover. And diabetes, as again, it's affecting the immune system and the neurological system itself. Having herpes zoster on top of that, it will increase the side effect and the conditioning for that. This slide shows you how, I mean, with transformation happening in the kingdom, again, cost is one of the indication, and that's why prevention now become priority for all cluster, all decision maker in top of the region and the kingdom. So herpes zoster is a very costly. It costs a lot of billion in United States. Cost estimated like 3 billion per year. That patient will be dispensed some medication or by having sick leave for that. So it's one of the major condition of cost disease. Thank you, Dr. Ashwin.
Okay, thank you so much, Dr. Ali. You have explained everything regarding the pathophysiology and the disease, and you went all the way to highlight the risk of patient with diabetes for herpes zoster, which is almost 40%, and even the post-herpetic neuralgia lasted for almost 6 months. So this is how the patient is subjected to this kind of infection and the consequences of the infection in terms of complications. Dr. Mohammed, the question is for you now. Can you tell us about how kidney disease can increase the burden of herpes zoster?
Okay, thank you, Dr. Ashraf, and thank you for Saudi Society for Family Medicine and Public Health for inviting me for this talk. First of all, as we know, the risk of herpes zoster, there are some potential mechanisms that increase the risk of herpes zoster with kidney or chronic kidney diseases. If we can see here, the CKD is, we know it is stages from stage 1 until stage 5, but if we take this in the left side, CKD from stage 1 to 4, usually those patients, they have accumulation of uremic toxins, oxidative stress, and endothelial dysfunction, and low-grade inflammation. And this will lead to impaired innate, innate and adaptive immune function that will lead, that includes T cells and B cells and neutrophils, and increase the or reduce the bactericidal activity. And this, by the end, lead to the increased risk of infection. Regarding the CKD stage 5 or end-stage renal disease, those patients, they will have accumulation of uremic toxins also with oxidative stress and volume overload. And this will lead to impaired adaptive immune function that will lead in impaired T cell activation and B cell. There is a decreased number of B cells. And there is an increased pro-inflammatory cytokines with regulatory T cells. Also, there will be an impaired innate immune function that will lead to decrease the reactivity of monocyte and reduced bactericidal activity of neutrophils. And by the end, it will increase the risk of herpes zoster infection. This is also, as mentioned by our colleague, Dr. Ali, that proved that the risk of herpes zoster, and there is association between the kidney disease and herpes zoster, and those patients with chronic kidney disease and polycystic kidney disease have increased risk of herpes zoster. If we can see with one of the meta-analysis with the large size sample that they mentioned with the risk of herpes zoster, it is higher with kidney or renal transplant, and followed by PD if we are talking about renal replacement therapy and hemodialysis. This is a study from Taiwan. It mentioned that the impact of kidney disease on herpes zoster disease, and usually the chronic kidney disease may increase the risk of complications like post-herpetic neuralgia. If we can see that as the control group, or the population of this study, almost 100,000 patients included in this study. The control group, almost 80,000, and they don't have CKD. And the reference, there is no risk of the post-herpetic neuralgia. But if we can see the chronic kidney disease, almost 16,000, they have or the risk of herpes zoster infection or complications like post-herpetic neuralgia is increased. Even if we have the dialysis patient, it is increased regarding the hemodialysis, and the peritoneal dialysis is more than hemodialysis. Even if we can see with the kidney transplant is more than what happened in the other modalities for renal replacement therapy. Even if we take the risk of post-herpetic neuralgia in people with chronic kidney disease, it will be affected by the age. If the age less than 60, they are more or they are higher risk of developing post-herpetic neuralgia.
The most common reason for chronic kidney disease in our society, is it diabetes?
Diabetes.
So imagine diabetes and chronic kidney disease together.
Yeah.
It's a deadly combination.
Yeah.
That subject the patient with this kind of profile for low immunity.
Yeah.
And that's why.
Yeah, actually, a lot of comorbidities that already with the slides that mentioned hypertension, dyslipidemia, cardiac disease, and diabetes, and sleep disorders. All of these will contribute with the chronic kidney disease to develop these complications and herpes zoster. There is an impact of herpes zoster itself on the kidney disease for the progression from progression of chronic kidney disease from stage to stage, even until those patients they end up with end-stage renal disease. As we can see here with the controlled group in this study, with those patients without herpes zoster or diabetes or hypertension, there is no risk of progression of end-stage renal disease. But if those patients has herpes zoster with diabetes, they are at higher risk for developing end-stage renal disease. And if they have diabetes and hypertension, they are more than those patients to have this progression.
Okay, thank you so much, Dr. Muhammad. And now we'll go to the most interesting part of our risk group, which is the cardiovascular. And here I would like to give the question for Professor Mustafa. What about the cardiovascular conditions? Can they increase the risk of herpes zoster? And we know that the cardiovascular condition is one of the components that build up the specific and unique profile of our patients in our clinical setting.
Well, Dr. Amir, thank you very much. First of all, I'm very happy to be with these very well expert people. And thank you very much for the company who invited me to share our information with the very expert group. First of all, I will ask the audience who thinks that he has not infected by herpes, varicella herpes. Raise your hand. Who is thinking not infected by varicella? Raise your hand. So one person at the age of 50, he thinks that he did not been exposed to the infection with varicella. So it is up to 97% of the population is affected by varicella infection. So all of us. Now, who thinks that his age now around 50? Raise your hand. No one, of course, all of you
No
young.
females.
Now, anyone at the age of 40, the immunity will start reduced. Then by the immunity reduction, then you are person susceptible to reactivation of the viruses by a new modalities, which we call it varicella zoster, because it was latent in the spinal ganglion and in the cranial nerves. But now with your immunity reduced, then it becomes, it's fire. So then you will have the complication by herpes neuralgia, and then you will have the blindness if it is happening to the ocular part and so on, and the pain and the loss of work and so on, and the cost. So many things will be on top of each other. My colleagues, Dr. Ali, clearly showed that the more the risk factor, the more likely you have you are susceptible for this infection. The question will be, who's of you treating patients with diabetes mellitus at the age of 50, and he's having only diabetes? Raise your hand. No one. It seems that all of your patients, they must have diabetes, dyslipidemia, hypertension, osteoarthritis. So they will have a bundle of risk factors. So all of your patients in the family medicine or in the subspecialty clinic, they are immunosuppressed with underlying comorbid condition, and they are at very high risk for the activation of the viruses from the ganglia. And then in that case, the treatment is very expensive and ineffective. So you have to think about the prevention. The treatment is the last thing. Now we will come to my part, which is the cardiovascular, which is very interesting. The cardiovascular playing two roles. The patient with a cardiovascular disease, he's immunosuppressed by definition. The patient who's not having cardiovascular disease, but he is at risk, or he had varicella, then he is at risk of development of cardiovascular disease. In another word, if you have a herpes zoster, you are going to have a stroke, myocardial infarction, and heart failure. Why? Because of the virus itself. Then I will let you know later on. The question addressed by Professor Ashraf Amir, can they increase the risk of herpes zoster, the disease itself? I'm sure some of you, they are taking care of hypertension, dyslipidemia, etc. All of those groups, they are at risk of cardiovascular disease, but they are at the same time, they are at risk of herpes zoster. So my patient whom I am treating, cardiovascular disease, coronary artery disease, heart failure, arrhythmias, etc., all of them, they are having a high risk for the development of herpes zoster. So what is the mechanism? A mechanism in playing in two parts. Part one, they are immunosuppressed, and all immunosuppressed, they are susceptible for the development of the herpes zoster. And then at the same time, they have the immunity reduction. All of the cardiac patients, whatever the comorbid condition and association, they are immunosuppressed. So with the immunosuppression, that you have degradation of the immunity response. So you don't have a defense mechanisms to fight against these viruses, and that's why you will develop the varicella zoster. And then once you develop this herpes zoster, then you are at the complication of all of those. You can see that not only the cardiovascular disease, but cardiovascular disease, rheumatoid arthritis, rheumatic fever or rheumatic heart disease, and then respiratory disease, etc. Name it. So many diseases can be coexisting with their risk factor. They are susceptible at development of herpes zoster. So herpes zoster is the enemy of any person who's at the age of 40 and plus, and they have a comorbid condition, whatever it is. The more the comorbid condition, the more likely you have. And then you can appreciate in this slide that the hazard ratio is very high for the development of herpes zoster in cardiovascular patients, particularly heart failure and coronary artery disease. If I may pause here and ask you, what is the recommended, how many of you vaccinated a patient, in adult patient, giving him a vaccine for herpes zoster or for pneumococci, or whatever you are? Anyone? So one person, he may be family medicine, or two. See, you can appreciate right now clearly that we are missing a big portion of prevention of our patient. We don't do that. Even pneumococci for heart failure or underlying COPD, we are not doing. This is very serious issue. So I reviewed the literature and I found that not only we in Saudi Arabia, but it is all over the world, undermined the utilization of vaccines in adults. So remember now that we have a new vaccine. Keep in mind to think about it. Similar to Dr. Muhammad and Dr. Ali, they start seriously thinking about it. They know it before, but they were not seriously thinking about it, but now seriously thinking. Why? Because since 2017, we start having the facility of having this recombinant vaccine, not a live vaccine. Live vaccine is worrying for all of us. But the recombinant vaccine is very safe vaccine, and it is only approved in 2017. It means it's approved only 6 years ago. And then they are worldwide approval all over. And now you should be aware that we have to play to do that with all. This is all a study from Taiwan, from international. By the way, you can appreciate the usual study we are doing, and all of us we are doing 500 patient, 1,000 patient, 2,000 patient. Now we will show you studies which done on 2 million patients. 2 million patients studied for the herpes zoster. You know why? Because it's very common. All of you have herpes varicella zoster infection. All of you. We can do the study on you, and then we know after 4 years how many of you will develop myocardial infarction secondary to your herpes zoster, and how many of you will have the stroke, and so on. So this is how they did the study in different parts of the world. The smallest study was done on 7,000 person who had the herpes zoster, the minimum study. But all of them, they are in 0.5 thousand studies in Taiwan, China, Europe, and US. US, they have done 205 health professionals. 34 of them healthcare providers from male side only, 34,000. And the remaining is female. And all of those female, they are professional nurses. And they have done the study, and they found that they are a very high risk of development, stroke, or myocardial infarction. Now I will ask you, what do you think the herpes zoster can cause more myocardial infarction or stroke? Stroke. More? Will the myocardial infarction more? It is stroke more. Very disabling the cardiovascular event is the stroke. So we are more susceptible to stroke than myocardial infarction. So I will ask you, if you have to have stroke or myocardial infarction, will you choose a stroke or MI? Stroke? No one like the stroke because he will be disabled. He will recommend a lot of people to take care of him. He will not be able to talk. He will not be able to eat. Heart, myocardial infarction. A lot of you can survive myocardial infarction compared to the stroke. So the stroke is more serious, and you can see from this slide, they are at a higher risk of development of stroke than myocardial infarction, but all of them, they are at risk of myocardial infarction and heart failure and so on. So this is the study from different parts of the world, and confirming all of them that you have the risk of development of this. However, there is a question here that what about the other way around? The other way around mean that you have either the herpes zoster will affect you and develop the infarction and myocardial infarction and cardiovascular event, or the other way around. You are a cardiovascular patient and you will develop the herpes zoster. So they are interchangeable. Each one of them will cause the other. And then I will show you this according to this question. I have found this published in 2022. This study published in 222, and this is the study I told you that it is done in 205,030 patients. 205,000. And they have done 2 million visiting studies on them. And look, herpes zoster and long-term risk of cardiovascular disease. It is recommended that they said has a herpes zoster and long-term risk of incidence of cardiovascular disease. In this analysis, which is the risk of cardiovascular outcome, stroke, coronary heart disease, or any one of them will start first. They found that significantly herpes zoster, independent associated with risk of major cardiovascular events, independent risk. So you have herpes zoster, wait for any one of those cardiovascular events. And of course, all of you hate to be in the stroke. The conclusion of this study said History of herpes zoster associated with higher long-term risk of a major cardiovascular event. These findings suggest there are long-term implications of herpes zoster and underscoring the importance of prevention and vaccination. So this is just published in Journal of American Heart Association, very respectable journal, in 2022. So that's number one. Number two, you can appreciate here, you can see that this stroke, coronary artery disease, and other cardiovascular disease in general, they are at very high risk of development of this stroke, cardiovascular and heart failure, and other cardiovascular disease because of the development of herpes zoster. Then how the herpes zoster can, and this is the proof, then how herpes zoster can do that, you can appreciate after herpes zoster, the early stage after herpes zoster, your risk of myocardial infarction and stroke will start. This is a meta-analysis of so many studies confirming that the first week post-stroke, post-herpes zoster, you will likely to have the highest risk of stroke. Then the risk will reduce by time. But in the beginning of the first week, month, second month, third month, sixth month, the high risk will be there. Now, that will be a different in cardiovascular disease. You can appreciate that it might start in the first week and it will progress similar to the stroke. And both of them, they are because of the herpes zoster. How herpes zoster can precipitate or can lead to myocardial infarction or stroke or heart failure because of something called vasculopathy. So the vasculopathy is there from those herpes zoster affecting the vasculature of the whole body, causing vasculopathy, and the vasculopathy will affect the cerebral arteries and the coronary arteries, kidney arteries, and so on. So you can, at the end of the day, this is a vasculopathy which will cause stroke because of the varicella zoster or herpes zoster infection. And this is a study just published in Vaccines 2024, herpes zoster and cardiovascular disease, exploring the association and the importance of preventive measure through vaccination. All vaccine should be done through the subspecialty or in general for the general practitioner who face the patients, these patients all in general. And then you can see this interaction. So herpes zoster can cause cardiovascular event, and the cardiovascular event can be a milieu for the herpes zoster development. So they are interacting together and they will produce what we call the events from the cardiovascular events. And then you can know that cardiovascular patient is a very high risk. He's diabetic, he's hypertension. We found in acute coronary syndrome in Saudi population, 60% of the patient with MI, they have diabetes, 60. So every 10, 6 of them, they have diabetes in association. And as our colleagues from discussed about the likelihood of diabetic patient and the kidney patient to have the problem of development of herpes zoster because of this. So what we have, medication is, as we have said, the efficacy is not great. All viral therapy, we are not sure whether they are really doing a work or no. It might minimize the course, but we are not 100% sure that it will cure, and maybe that will be commented by Dr. Ali later on. But the vaccine as a prevention is very important. And we said that this vaccine's advantage of this vaccine is very safe, and it is not an active or attenuated virus. It is not live vaccine. It is just recombinant made in the manufacturing company of the drug, and then they produce this. So now you want to ask for the prognosis. Is the herpes zoster affecting people? It has a better prognosis compared to the control. Now you will look into this. Survival means the likelihood of these people to survive. If they have herpes zoster, their survival is 50%. Yani 50% of them, they will die. But if they don't have, then the survival is 74%. So only 25%. So there is a difference of at least 25% in terms of survival. Yes, our colleagues from infectious disease said that they are not less likely to cause a reduction of the mortality by vaccine. But in reality, once you have the immunity decrease, the herpes zoster developed, the cardiovascular event is there, other problem can involve and can, attack that person, and then it will reduce his expected life. So it is very important to think about one or two injection in reality to reduce this. And this, as you can see, this is only published in 2023. Now, in another study published in 2022, telling us the short-term prognosis. The short-term prognosis in how many patients have been studied? 16,611,501. Why? Because all the people is involved. This is a very massive study because all of you, and I will swear that you have the infection during your life up till now. So what happened that the age over 75 having the highest hazard ratio for the development of the herpes zoster, liver cirrhosis, chronic kidney disease, heart failure, and all cerebrovascular events. So they are all at a higher risk of development of herpes zoster. So that's why the reason is that we are not proactively doing job to reduce it by thinking about vaccination. Why? Because the proper vaccine was not available until 2017. Before that, it was live attenuated vaccine, which is contraindication in so many times. Now we have different things to go for. So here I will stop for our chairman, and then we will see what is next.
Thank you so much, Professor Mustafa, for this wonderful illustrations. And I would like just to remind our attendees just to prepare their questions. It will be at the end of this session. And we are accompanied by virtually attending colleagues. So please try to put your questions in the Q&A box so we'll be able to deliver to the concerned speaker at the end of the session. Dr. Ali, what do you tell us about recombinant zoster vaccine? So,
well, my talk will be difficult after Prof. He spoke about it. Thank you, Prof, for your speaking. So again, we have two types of vaccine. We have the live vaccine, which was hold, and we have the recombinant, which is actively available since 2017. So it is basically composed of two agents, which is the antigen and the adjuvant, which is basically the booster, which will give it the vaccine, the efficacy to give the immunity for the recipient who receive it. So the possibility of having a recombinant or adjuvant vaccine or non-live vaccine that you can give it for wide section of community. So you can give it for patient immune compromised, immune competent. This is unlike the live vaccine. So it is basically a non-live glycoprotein E subunit vaccine. It is 2 doses. It is given intramuscular. The duration between the first and the second dose, it's 2 to 6 months usually. It can be stored in a refrigerator, so it will not take advanced or high-tech equipment to be refrigerated or stored. And there is no contraindication to give immune compromised status patient for that. So patient will go for transplant, HIV. Those category of patients can receive the vaccine very safely. This is just structure of the vaccine. As you can see, it has 2 components, both of them 50 microgram. This is the antigen, and this is the adjuvant. And you can see the adjuvant, and this is, it is given intramuscular. Usually we give it in the upper arm. And once it's reached the serum, the adjuvant, you can see it will give a boost of the immunity, and that immunity, in multiple studies, it shows that it will stay for 7 to 10 years. So it is very effective if you receive the 2 doses vaccine. Without the adjuvant, the immunity will not reach high level, and it will be declining over a few months. So if you want to assess the efficacy or safety for this vaccine, or actually any vaccine, it is basically checking the RCT and study, as mentioned by Dr. Mustafa, that studies is the modern medicine. So whenever you have a huge number of study or population, and that's the way we assess the efficacy and safety of any vaccine or any treatment. And one of those study was the Zoo 50 and Zoo 70. This is basically randomized, observed, blind, placebo-controlled, multi-central, multinational in both Americans, European, and Asia Pacific. they took two categories of patient. The first arm will be above 50, and the second arm will be above 70. And they give them either the vaccine or placebo, and they monitor the outcome for those categories. So those data are available for 3+ years, and those patients either receive placebo again or the vaccine. You can see the first outcome, which is the first outcome having the HSV itself. If you can see overall, the patient above age of 50, basically the patient on placebo arm, they have reached up to 10% per 1,000 having the HSV compared to 0.3% in patients who received the RSV vaccine. And also, if they compare the post-herpetic neuralgia in those patients as in terms of developing comorbidity or not.
Yeah, thank you so much, Dr. Ali. Dr. Muhammad, we'll go back again to your contribution. So what is the safety profile of the recombinant herpes zoster vaccine?
Okay. As we mentioned before with the previous studies, the overall incidence of serious adverse events, death, and what we call potential immune-mediated diseases were similar in all groups, either with RSV, recombinant zoster vaccine, and the placebo. For the any grade and grade 3 solicited local adverse reaction that was reported in the ZO 50 and ZO 70, we can find that almost it is the proportion of patients is lesser with the ZO 70 than ZO 50 because of the age and the decreased immunity in terms of any grades or pain, redness, or swelling. Also with the systemic adverse reaction, it is almost below the ZO 50 for the patient age 70 and above.
Okay, Professor Mustafa, back again to you. How long do you think this vaccine will remain effective? Effectiveness is another issue has to be considered in this.
Now, of course, thank you very much again. You know that once we talk about the effectiveness, we are always getting in mind the possibility of the side effects of anything. Who thinks that vaccine causing nothing? Causing nothing. Who received the vaccine for COVID? Raise your hand. I'm sure all of you, by law, you have received. So there was a reaction, but those reactions were so severe compared to this reaction. The reaction here is almost like placebo. But of course, any vaccine, regardless, only even from the injection itself, that's considered side effect. But the major side effect, you know what they consider here? That if you have a red reaction of 8 or 10 millimeter, considered to be severe. A reaction, simple reaction, has nothing to do with fever or anything. And then I will tell you within this effectiveness, I will tell you what is the safety after extension of this. So to summarize this, the effectiveness will remain there up to 12 years. You know, most of the vaccine is lifelong. Mumps, rubella, and so on. We take it only once. But the vaccine for flu, we are taking it every year if the person is susceptible. And similarly, the vaccine for the Hajj, we are doing it every year, just from precaution. And similarly, pneumovax might be used recurrent, but the major vaccines is there. Now, about these vaccines, I will show you the study, which is the extension of the study mentioned by Dr. Ali, that from the study of 50-70, they extend this study from the end of the previous study 50-70. Why 50-50 the age group, 70 the age group? They consider that, they name those study 50-70 studies. So for the 50-70 study, after that, there was a gap, stopped any follow-up for those patients, 1 year extra. So 50-70 completed, reported in a very respectable journal, then disconnected from follow-up all of those patients for 50, 70, 1 year. Then after that 1 year, they think that we have now to go back to study those patients. So they collected all the patients they can collect from those who received the vaccines, and then they studied them for another 4 to 5 years. So what was the question about this? As our chairman said, Dr. Ashraf, that the safety and the efficacy. So that the efficacy will last for how long? And the safety, how safe it will. You can see that this is an extension of study. They call it extension from 50 to 70. The population is the same population. Anybody or anyone who had the vaccines at the age of 50 and more, he was included as much as they can collect. And then they call it Zoster 49 study. Al-awwalaniya 50, 70, and this is 49. Easy to remember study, except in cardiac patient, we have so many studies, we cannot remember all the acronym. But in this one, 50, 70, and 49. And I'm sure most of you under 49. So 49, the study names because it is involving the extension of the previous study. So what is the primary endpoint? Efficacy. What does it mean? Efficacy in producing good immunity in the cellular immunity and humoral immunity. So in the production of CD4, the T cell production of CD4, and in the production of the antibody for the humoral immunity for the vaccines. So this is the efficacy. If you can detect those later on, then the efficacy is there. So that's what you can see. Then there was a secondary endpoint for the efficacy as well. The efficacy including from the last 4 years after the break of 1 year, and then the efficacy looked into the whole cohort from the first dose of the vaccine up to the end. This is the diagram representation of what I told you. Now you can see that the blue arrow is the first 4-year study. In between, there was 1 year gap. Then the red Zoster 49 extension started, as you can see in the red arrow. So what they said, what they found, that they found 7,277 patients they could collect to study them. So what they found, this is from, they studied the part of after the 5th year, and then they studied the whole cohort. They found the efficacy in production of the humoral and cellular immunity is 81.6 for the remaining last 4 years. So 4 years plus 1, 5 years plus 4, 9 years. So for the last 4 years, they found that it is 81.6, almost 82% efficacy. In another word, 82.6 of those, 81.6% of those population, they have positive humoral and cellular immunity by the CD4 measurement and by the humoral immunity antibodies and immunoglobulin E. And then the whole cohort, if you look for the efficacy, it was 89% effective. In another word, 89% of those patients, analyzed for the production of the humoral and cellular immunity, it was positive. So the extension up to 10 to 12 years, you will have still production of antibody and cellular immunity standing. So that's the answering for the first question. So, well, the second question about the safety. The safety, they look into all the possible problem, as Dr. Al-Omi said, that there was almost placebo-like. However, they consider that if the patient having a temperature of 38, it is a major adverse event. الحرارة دقتنا أكثر من 24 ساعة بعد الكوفيد. And when we relieved, we استسلمنا. This is only at any time you report a temperature of 38, they consider it major adverse events. Or more than 10-meter reaction for those, they consider it more adverse event. And you can see, there was one patient at the age of 88, he developed post-herpetic neuralgia, one person, but his age was 88. And then since the second dose, it was after 6 years. So his immunity reduced after 6 years because he's 88 years of age. And it was resolved. The patient did not die. Second patient at the age of 80, he developed the disseminated disease, disseminated herpes zoster. This is a very serious issue, and Dr. Ali might elaborate on it. But this is after 7 years and 3 months from the beginning of the vaccination. But again, he recovered. The third and fourth and the fifth patient, the third and the fourth patient, they have developed post-herpetic neuralgia. And then, but we are not knowing when after herpes zoster vaccination. And then it is, over 9 years, since the injection. And then it is again resolved, both of them. The last one was disseminated disease in 81 years old, which we don't know the herpes zoster episode. Episodes of herpes zoster, how frequent. Then approximately 9 years, and it resolved after the checking, after the point of 4 years after the follow-up. So this means that the drug is safe, the drug is effective even up to 10 years. And I have found a study that the study I found that there is a study said that up to 12 years they found that the effectiveness is still present. I'm not sure whether there is still some slide for me. This is the vaccination against the diabetes mellitus patient. There was the likelihood, 91% of the diabetic patient, they might develop the herpes zoster, 91. So it is very clearly more in diabetic. Renal disorder, a patient of almost 80%. Then you can see in the hypertension, dyslipidemia, coronary artery disease, heart failure, they are all people, they are at risk of development of herpes zoster, and this is why they deserve to be vaccinated. And the vaccine is very safe, even if you have more than one of these risk factors, they are still can be used, and the safety profile is quite high in all of those patients with any underlying comorbid conditions. And then here we will make a discussion under supervision of our chairman,
Thank you.
which he managed this conferences very well. But I will ask you, all of you, do you have any change of mind toward the vaccination, particularly the herpes zoster, which you never started vaccinating your patient? This is the first time. Will you initiate thinking about not doing? Of course, you doing is better. About the vaccine, raise your hand. Wallahi, we convinced only 2 people after all of this talk. Huh? Okay.
Yeah,
all right. I think we are in the right direction.
Okay, thank you so much, Professor Mustafa. Now, I think it's time now just to explore the international and global recommendations for recombinant herpes zoster vaccines. So I will just open the floor now for all the speakers.
Worldwide, we have the CDC. So the CDC has approved the vaccine. Locally, we have the Saudi MOH and the Saudi FDA also approve it. You have the UK, Canadian. So you have the mega Western countries, they approve the vaccine already. And it's, as mentioned by Prof, it's started to be vaccine with millions of people.
Yeah. Okay.
In the same concept that you can see that in more than 51 countries worldwide, including United States, which is very difficult to approve any medication in the state until and unless it is very well studied and if they approve it, etc. But in these 51 countries has been approving the drug. But the recommendation only in 26 countries recommended. And then some of the society again recommending. You might ask whether the guideline is there for this sort of recommendation. The answer is not there. Despite that the study is overwhelming in millions of patients and clearly, but the issue of the guidelines, it is not yet on the guideline. Why? Because it is only over the vaccine is approved at 2017, 6 years ago. And then they might need a longer follow-up, and then they might require some more specific study, particularly because of this, the population is huge to be vaccinated, huge. Almost everyone at the age of 50 has to be vaccinated, even if you have dyslipidemia alone. So why there is no guideline? Because the guideline, they are always keeping the guideline with the balance of the costs. So massive cost of vaccination for everyone at the age of 50 might not be justified for the guideline to go. But as our colleagues, Dr. Ali, he is an expert infectious disease consultant, Saudi Arabia, particularly the Family Medicine Board, they approved the vaccination for their patients who's having any one of these comorbid condition or who's at any age from 50 above, because there will be very, very infrequent you will find the person at the age of 50 in Saudi Arabia and he's not having an underlying cardiac condition, diabetes, hypertension, or dyslipidemia at all. And you know that the Saudi population, we have done a study in King Saud University, and we found that Saudi will have diabetes 10 years earlier than any other population. يعني مميزين احنا سعوديين. Saudi will have dyslipidemia 10 years earlier than anybody. Saudi will have a stroke 10 years before anyone. Saudi will have the myocardial infarction 10 years earlier than any other comparative population.
Yeah.
And Saudi will die 10 years earlier before any other population. So
That's right.
so that's mean if the recommendation for 50 in this study for the European population or the Asian population, we should recommend it at the age of 40.
Absolutely.
Because clearly those population, they die after us by 10 years. So we should start our prevention, in fact, 10 years before the Korean or before the Japanese. The studies of these two category in the Asian continent, and then Europe and US. This is why that I think the recommendation should be as early as possible, and it should be maybe in the beginning you will give it for the high risk because of, I don't know the cost, but the cost will be a key. The government will negotiate about it, but we have to have the culture of prevention. Unfortunately, all of us, particularly the cardiologists, they are all directed for intervention. They will do the angiogram and the cardiac catheterization. We are interested to do that. If we are unable to do that, our income will be very well reduced in the private sector. We will receive only our salary from the government because we don't have job to do.
Yes, I really second what you have said, Professor Mustafa. There is a very nice statement said by the American Academy of Family Physicians. They said, if a patient comes to the emergency department with acute coronary syndrome, and he went to the cath lab for stenting or CABG, he will be counted as a failure of the primary care physician who's sitting in the other spectrum of the healthcare system who did not do his preventive services appropriately. So this is what will hold in all of us the responsibility and the commitment towards securing the prevention rather than, and even our healthcare system in the kingdom now, during the transformation, we are moving from intervention to prevention, from disease to health, from illness to wellness. And as you said, Prof, we are dying 10 years before the other populations. And
congratulations, all of us.
and to say, and it's really true statement. Why? Even because of diabetes, there is a pre-diabetic state, which is usually 7 to 8 years or 9 years before the onset of diabetes. And all the studies show that the pre-diabetes is a clinical entity. It's a disease because it's associated with comorbidities and mortalities and morbidities for microvascular and macrovascular complication. So imagine how many of us, 37% of our population, they are in the pre-diabetic state, and they are subjected to peripheral neuropathy, renal impairments, and so forth. So definitely the risk is huge, and our population at risk. And this is really the momentum that we have to take to ensure that we do the best for our populations. Any other commitments regarding the guidelines?
If you want us to, as we said, but Dr. Ali is here, might comment in a better way, that we have two vaccines in the market for now, the live attenuated one and this recombinant one. The recombinant one recommended in majority of countries and in majority of underlying conditions, underlying comorbid condition, regardless what is it, because it is safe and effective and has no reaction compared to the live attenuated. The live attenuated, probably for the young age group who might have not having a significant or a lot of comorbid condition. We want to mention here one categories of group of patients. They are very common, and I am sure most of the family medicine, they are facing those cases, is the respiratory disease patient. bronchial asthma, COPD, chronic bronchitis. They are all there. They are supposed to receive the other vaccines. But these people, they are using, some of them, they are using glucocorticoid. And then glucocorticoid, we know that it reduces the immunity further. So your immunity is reduced. You have disease to reduce your immunity, and then you are using cortisons or whatever drug from the glucocorticoid group, which they further reduce the immunity. And subsequently, this group of patients, they are entitled of vaccination of attenuated type more than the other categories of patients. So today we have renal, we have diabetes, we have infectious disease, but at the same time, we have the main gate of the family and clinical practice medicine. But the most important thing is that you should know that all of these comorbid conditions need an attention, particularly for the family medicine and the general practitioner who face these patients more frequent. You know, the appointment in my clinic is 8 months for the patient to be visited me. So for you, maybe every month, the patients can come for the family medicine or for the primary health care or for the general practitioner.
Thank you, Prof. Mustafa. Well said. In fact, on your behalf, ladies and gentlemen, I would like to thank all the guest speakers, Professor Mustafa, Dr. Muhammad, and Dr. Ali, for their wonderful illustrations and presentations that tackle all the different aspects of the topic. And now we would like to open the floor now for questions. So I will give you the privilege of questions. The physically attending audience, please. Mike, please, over there. And I have received some of the questions from the online as well. We will forward it later.
Yeah, we forget to thank our audience from the Zoom.
Yes.
They are almost reach 1,000. That's why I'm talking to them. You are a small group compared to 1,000. We are really talking to 1,000 people outside the arena here, and they are watching our talk. Thank you very much for all of them and for staying with us all of this time.
Okay, thank you.
Just introduce yourself, please.
The question is for Dr. Ali. I'm speaking, there is a fact.
Introduce yourself, Dr. لو سمحت. Introduce yourself.
فتحي البسيوني, consultant nephrologist, King Salman Kidney Center.
Thank you.
So I'm speaking about the response rate, especially in immune-compromised patients, as there is most of immune-compromised patients are allergic to produce antibody. So parallel to hepatitis B vaccine, as in dialysis, usually we are following with antibody. Is there any definition for responder to varicella zoster vaccine, recombinant one? And if there is any regimen, especially in immune-compromised, I'm speaking about HIV transplantation, is there any frequent increasing dose, for example, or frequent vaccination?
Excellent question.
Thank you.
So actually, for those category, first of all, we have the antibody for varicella. So we can order the antibody and you can know the titer that the patient immune or non-immune. So this is the first part. For immune compromised status, so it's majority of studies notice that if they receive only one dose of the vaccine, they will reach some sort of immunity, but it will not reach as much as if they receive the dual dose. So it's compared to the general population, if they receive one dose, they will have actually good immunity. But immune compromised status, nephrology patient, HIV, rheumatology patient, they need the second dose to reach that booster and that steady immunity in their body.
Yeah.
It's not recommended because, obviously it will be, and the majority of them, they will have the immunity. Hepatitis, it's a different entity in renal patient because, you will isolate them in specific for infection control measurement. You will not keep patient on dialysis. He's hepatitis B with the patient non-hepatitis B. Plus the needle stick injury and it reached 30% for hepatitis B if the healthcare worker has a needle stick injury for them. So hepatitis is a different entity. That's why we need to know the immunity for our patient.
Yeah, Dr. Fathi, if I just to complement what Dr. Ali said, but the time we reviewed the topics related to this, and we found that after 9 years, the immunity sustained 5 times more than the control. In this study of 50-70. five-fold, 5 times more immunity sustained compared to those who did not take in the vaccine. So in general, maybe in detail of what your question, Dr. Ali answered, but in general, for the relation to this effective vaccines, producing after the 10 years, it produced 5-fold increase in the immunity to fight against the infection.
Okay, any other questions? I just want to ask regarding the second dose, how do you look into the second dose in terms of compliance? We have been successful to implement the first dose, and I think we reached 37% according to the latest study. But the second dose did not reach the appropriate coverage that we would like. So you comment on this. What are the reasons?
Let me start. I think this question should be forwarded to the audience. The audience, how many of you received 3 times vaccine for COVID?
All of us.
Yalla. So if you have the same campaign to make the awareness
And
for
technology
the
also technology, Prof.
Yes.
You know, at the time we have received an SMS
Yeah.
notification.
yes, okay, that's awareness.
You need,
Yeah.
you need.
That's awareness.
Yeah.
If you have that much of awareness,
Yeah.
or if you have 10% of that awareness, the 2 doses every month, 1 dose is very small thing.
Absolutely.
Yeah.
One of the reasons could be, again, because of the durations for the second dose between 2nd and 6th, 2 months and 6 months. So this is a very big gap, and many of our patients tend to forget. So that's why we make a decision in my hospitals and the area we are taking care of our patient to make it mandated after 2 months. So there is no way for anyone to forget, and there should be a follow-up on SMS messages for them. So we picked up, this kind of coverage to some extent.
Yeah, but the problem, you're talking about the MOH. يعني what I mean, each primary health care, for example, will cover 1 million population.
They cannot
Yeah.
follow all
Yeah.
of them, obviously.
So you approved that in your
But I think
cluster, right?
technology, it's supposed to
You
be the
approved
answer
the
for
product.
that.
Absolutely.
So
Whenever you
Dr.
have the vaccine,
Muhammad
it should
saying that
calculate for more
in his
simple
cluster, he's the responsible person in cluster 2 in Riyadh.
No,
Huh?
the kidney. تفرط معي.
In the kidney patient. Yeah, for the kidneys. For the kidney. They approved this drug ولا لا?
Yeah,
Yeah.
already we started. already.
Yeah, they approve it and they started already. So the family medicine or the practitioner, general practitioner, I think the main load is depend on them
خرب.
because they are the front gate
Frontline
for
workers.
these things.
Absolutely. In certain hospitals where we have some kind of IT and technology can be implemented to help us to capture those patients. What we have done in the International Medical Center, in the triage, anywhere across the board, the nurse will take the vital sign. The 6th vital sign is a question. Did you receive your vaccine for herpes zoster if the patient is 50 years and above? And if he's not, she will flag the system, and the system will be alerting all the physicians across the board that this patient is eligible for the varicella zoster vaccine. And this should not be counted as a missed opportunity. If this particular patient leave the hospital without having the vaccine, so we're losing a very precious momentum and encounter with patient. So we can do this also manually. So technology should not be the obstacle. But the moment we think about the patient from different perspective and put the patient in the center, definitely will come up with a certain idea to improve the compliance.
Yeah,
and the
but
coverage.
Dr. Ashraf, if you allow me, and I'm sure that you will comment about what I will say, the governmental sectors, their concern about or their care about the prevention is compared to the private probably is less. I will think that the private sector, because they in order to increase the income, to increase the patients to come, etc., it become easier for the private to invite those cases of requiring vaccination. Because the patients in the governmental sector, they will have difficulty doing things, and if there is no clear pathway in each institution.
Yes.
Maybe in the private is easy to go and then I say, do you have vaccine? I want to do it for this and that.
Yeah.
And I am sure during Hajj period, you will see a lot of people, they are coming to the private compared to the governmental sector.
Absolutely.
I think you have a major tasks to invite the public to be vaccinated.
Absolutely, yeah. And we
for
issued
this
the-
particular
Absolutely.
situation.
Online questions.
Yes.
Yeah.
Go ahead.
okay. First question goes to Dr. Muhammad. What is the mechanism of progression of CKD into end-stage renal disease after herpes zoster?
What is that?
Mechanism of CKD into end-stage renal disease after herpes zoster disease.
As we mentioned, it will affect the innate and the humoral immune system for those patients, and they will end up with this infection of the progression of this end-stage renal disease. Actually, as you know, the CKD from stage 1 until stage 4, they have urine or uremic toxins and the oxidants accumulated. So after that, if those patients they will get those infections, the oxidative and the effect of the immunity, it will progress to stage 5.
Great, thank you so much. Prof. Mustafa, we have another question. Does the vaccine prevent stroke or MI?
Okay, according to what we have, yes, because we compare a population who does not receive it and the population who received it. And they found from the first week after herpes zoster development that the cardiovascular event will start. And it will start more frequent in the early stage, but it will become less and less. And the pathophysiology is very clear that there is in addition to the immunity system, immunescence or degradation of the immunity, there is a vasculopathy as well. So it is very well clearly established. The question about the mortality about herpes zoster, that you might not have a clear-cut mortality, but the subsequent of the development of herpes zoster with the whatever will have, stroke, myocardial infarction, heart failure, etc., is very clear. There is no doubt about that this is a predisposing factor, and the study was clear, including the survival. The survival in the control group was 74. Meanwhile, the survivor in the people who had the herpes zoster infection, 54. So it's clearly preventive.
Thank you.
Excuse me, if you just can maintain the quiet, please. Excuse me, quiet, please. Huh? All right, there is 2 questions. In fact, I will just forward it. We know that the vaccine is given to 50 years and above. If there is any chance for less than 50 years, and what is the conditions?
So if patient immune compromised in terms of HIV, or he's transplanted or plan to be transplanted, those patients can downgrade up to 18 years and above. So you can give them those kind of vaccine. Also, another category is it's the iceberg, as mentioned by Prof. The patient who receives steroid, rheumatology patient, respiratory patient. Those category are most likely they will receive a lot of steroid during their life. So those considered to be immunocompromised.
Dr. Ali, why, it's a question for everyone, why we are seeing more cases of herpes zoster nowadays? Is it because of better reporting, better awareness, or because of the immunity which has been decreased after COVID?
So I would say both. Regarding immunity, I would say because our community, I'm with the Prof. Mustafa that we are dying 10 years before, but our community now is growing up. The latest, the ministry here said that we reach about 70 plus as an average age.
And it's supposed to be 80 by the year 2050.
Exactly. So our community now, we're seeing elderly. So we are seeing more cases because of awareness, education. Previously, maybe if you go 10 years ago, we did not have family medicine in each primary healthcare as we have now, and as we will have in the future. So we have more frontliner. Our ER now more educated. We have more programs, more educated, more board certified. So they are self-reporting, of course.
Absolutely. Thank you. I think we finished because there is no more questions. But ladies and gentlemen, I would like just to, I would like you to scan the QR code and to answer the questions. It will take another 3-4 minutes. So please do. And for this, there's a question for you, but quickly, please. One question here. Yes, we can give, yeah. So we have to wait maybe for 2 weeks or 2 months?
Yeah, it's dependent on the infection. So personally, I will not give patient on active tuberculosis, for example. But I mean, if he has pneumonia or UTI or skin infection, so I will wait, depend on the case for a few weeks before I give him. But it's not contraindication.
She was talking about if the patient has a
Herpes.
Herpes zoster.
Herpes, of
How-
course, of course. I
Wait,
mean,
wait.
you will wait until the skin is
Exactly.
crusted. Yes.
2 weeks, yeah.
What's that?
After 12 years,
So the guideline, or at least the recommendation now, there is no booster. It is 2 doses because it's supposed to give immunity. But I mean, this is preliminary question. The data and the studies will give us the answer in a few years.
okay. So coming to the end of this sessions, I would like to thank you for being with us here today. And on your behalf, I would like to thank all the guest speakers, Professor Mustafa, Dr. Ali, and Dr. Muhammad, for their wonderful contribution and enriching our scientific event with a lot of thoughts, a lot of expertise. And please, ladies and gentlemen, as we have been going through the different aspects of the disease, now we have learned that the disease is a devastating disease. It's disabled the quality of life of those patients with herpes zoster complication like post-herpetic neuralgia. We have identified the population at risk: patients with cardiovascular disease, patients with renal problems, and diabetic patients, and so forth. And it has been very clearly illustrated elegantly by all the speakers, the association between these diseases and the enhancement of the comorbidities and mortalities. And it's as said elegantly by Professor Mustafa, herpes zoster infection by itself is an independent risk factor for the cardiovascular mortality and morbidity. So the vaccine is available in all the sectors, private and even the government in primary care, and it is efficacious, safe vaccine with a very promising outcome that with it we can save the health of our community. With this, ladies and gentlemen, I would like to thank GSK company for sponsoring this event, and I would like to extend the thanks to the Saudi Society for Family and Community Medicine, having this kind of scientific activities going for many, many years under the umbrella of the scientific committee. Special thanks to ملتقى الخبرات and لتنظيم المعارض والمؤتمرات for organizing this wonderful event. Thank you so much for you, and wish you a good practice, and I wish you all the success all the way through. Thank you. الله يعطيك العافية. Thank you so much. شكرا. The lunch will be down in the ground floor. Okay, so you can go ahead. Thank you.